thanks for joining this next session on patient navigation, reimbursement, and sustainability, presented by Elizabeth Franklin and Sally Warner. My name is Marcy Sansbury. I am a project manager in the education department here at Cancer Support Community, and I will be helping to moderate this session. Before I introduce our speakers, we have a few housekeeping items I'd like to cover first. The session is being recorded and will be available for viewing after the event. However, continuing education credits can only be earned by attending this live session. If you wish to receive a continuing education credit from participating in this session, you must complete an online evaluation form, the link to which we made available at the end of day 1 of the symposium. If you'd like to ask a question during the presentation, please do so using the Q&A feature in Zoom. While some questions may be addressed during the session, we'll do our best to address all remaining comments and questions during the Q&A session at the end of the presentation. To turn on closed captions, please click on the CC button in your Zoom toolbar. Now, I'd like to introduce our presenters. Elizabeth Franklin is an advocate for people impacted by cancer and is passionate about ensuring that patient voices are the North Star in healthcare decision and policy making. Elizabeth has spent 2 decades as an oncology advocacy leader and has significant expertise in professional social work, research, and public policy. She currently serves as the head of U.S. Public Affairs and Patient Advocacy Oncology with Sanofi. Elizabeth previously held positions as president of Cancer Support Community, as well as the George Washington University Cancer Institute, Prevent Cancer Foundation, and National Association of Social Workers. She earned a doctorate from the University of Maryland School of Social Work, her master's degree in social work from the University of Illinois at Chicago, and her bachelor's degree in social work from the University of Kentucky. As an oncology nurse and health administrator for over 20 years, Sally has worked in diversified healthcare systems, nonprofit and for-profit hospitals, and provided executive operational oversight for all areas of cancer service lines, including cancer research, cancer registry, supportive and outreach services, radiation oncology, infusion centers, inpatient oncology units, and centers for breast health. She has also had operational oversight for home care, hospice, and palliative care service lines. Over the last 7 years, Sally has led operational and strategic oversight for Cancer Support Community. Previously, as the Chief Experience Officer, Sally managed the CSC network of over 190 locations, program, education, research, and strategic growth. Presently, as the Chief Executive Officer of CSC, Sally has a distinct pleasure of supporting all aspects of service for the global nonprofit. She not only ensures that the mission of CSC is carried out with fidelity in local communities across the globe, but also drives the organization's strategic objectives with a focus on growth, innovation, health equity, brand awareness, and diversified fundraising. Please welcome Elizabeth Franklin and Sally Warner.
Thank you so much, Marcy. It's really exciting to be here. By way of Sally's biography, you know that when Sally asks you to do something, you say yes. So I'm happy to be here and really excited always to partner with Cancer Support Community. So I think folks heard my background. If I don't know you, which I know many of you, I saw on the participant list I do. As a proud social worker, I'm just so thrilled to be here and really excited to talk to you today about the state of navigation, because it has been it's been quite a year in terms of navigation, reimbursement and sustainability. And so in addition to the work that I do at Sanofi, which, you know, that's my day job, I'm very lucky that they allow me to continue some of this passion that I have around navigation. And so I co-chair the policy work group with the National Navigation Roundtable, do some work with AOSW, and I'm on the leadership council of the Academy of Oncology Nurse and Patient Navigators. So I just really think navigation is critically important. And as you're going to hear today, Again, it's been such a fantastic year for navigation, and I'm excited to see where we go from here. So we wanted to provide you with some background on where we are, where we're going, what it looks like, and answer any questions that we can. So briefly, I will just say my relationship, I work for Sanofi. So obviously that's my disclosure. And I know Sally had no disclosures to report. All right, so today we will talk about, again, the background of navigation, where we are. Currently, we've gone almost overnight, really. It seems that way, but it's been years and years in the making of having navigation reimbursable as a reimbursable service. So we're going to talk about the different methods that a navigation can be reimbursed, both in this moment and then also looking forward. Then we'll get to some frequently asked questions. There have been a lot of questions that have come in, a lot of discussion in terms of what does this look like? How can I navigate? No pun intended, the codes, and how do I move forward? So we'll talk about that, and then hopefully we'll have time at the end for discussion. But I'm happy to share my contact information. I know everybody likely knows Sally's. Happy to help after the webinar if folks have questions. I do not pretend to be a billing and reimbursement expert, but I do think I have a lot of knowledge around navigation, and we can find the answers if we don't have them. So that's my promise to you as we go through what is going to be a pretty technical presentation. All right, so I wanted to start with the navigation standards. A couple of years ago, we were very fortunate to come together, and you can see the groups on this slide: the Academy of Oncology Nurse and Patient Navigators, the Oncology Social Workers, the Pediatric Hematology Oncology Nurses, Oncology Nursing Society as the professional organizations, along with the Cancer Support Community. I was working with CSE at the time, as well as the Smith Center for Healing in the Arts. And we came together, and this was really an offshoot of what was then the White House Cancer Moonshot, and then ultimately the Biden Cancer Initiative, which had done a ton of work around navigation, right? It had done, really, where is navigation heading? How can we support navigation? And one thing we determined through that work was nobody really knew what navigation was, right? If you've seen one navigation program, you've seen one navigation program. And to a certain extent, that's okay. I think it'd be similar if you've, seen any sort of professional program. It's going to differ depending on the community you're in, right? My hometown of Lexington, Kentucky is going to look different if you're at the University of Kentucky than, New York City, right? Versus where I worked at GW in DC. But we know that there has to be standardization and definitions in order to move policy forward with navigation. And so, and an example of what that looks like, there was legislation out to provide reimbursement through Medicaid, the state level reimbursement structure, to provide reimbursement for navigation. And within the legislation, it was federal legislation, navigation wasn't defined because it hadn't been defined. And the Secretary of the Department of Health and Human Services would be able to set a committee to define navigation. And I don't know about the folks on this call, but as a professional social worker, as somebody who's supervised navigators and worked in this space for a really long time, that made me uncomfortable. Not knowing who would be on that committee, not knowing who would develop the definition of navigation, and kind of leaving it to the government made me pretty uncomfortable, right? Because it needs to be the professionals who are doing this every day. So we brought together the professional organizations you see on this slide. And then we also thought it's important for CSC's voice to be there as a voice for navigators in the community, as well as the Smith Center for Healing in the Arts, which is a nonprofit based in Washington, D.C., to come together and define what navigation is. So that's exactly what we did. And we've got a link at the end of this presentation for you to access those standards. So it not only defines navigation, but it also lists out, what are the base level of expertise that different types of navigators should have, whether it's nurse, social work, or what we call patient navigators. You may have heard them previously called lay navigators, and that's not really the language that is used anymore. So we talk about clinical, nurse, and social work, or patient navigators, those who may not have that clinical license. Come together, let's define who they are, what they do, and how they do the work. So this is a really important source document for everything that we're going to talk about today. So like I said, the goals of the navigation standards. Enhance the quality of professional navigation services. What is that level that all navigators should be able to offer? But recognizing that every navigation program is going to be specific to the community. So it will ebb, it will flow, it will be different depending on the community, but there needs to be a certain level of standardization. They allow us to advocate with and on behalf of patients, survivors, families, and caregivers. Encourage navigator participation in the creation, implementation, and evaluation of best practices, right? This document is not a static document, it's a living document. And if folks have questions about how we will update this and what that looks like, Sally and I are still participating in the task force that's really holding the standards and making sure that they're updated with time. Promote navigator participation in public policy, which is incredibly important. The story that I told about legislation, this is why it's important for our voices to be heard and to make sure that we are setting the path that informs legislation and policy. To best support the interests of people impacted by cancer, if I were going through a cancer diagnosis or someone in my family, I would want to know that the navigator they were seeing had adhered to a certain level of standardization. And then finally, this document is an education tool. If anybody off the street picks it up and reads through the standards, they'd basically be able to say, okay, I have a pretty good sense of what a navigator does. So this is the first time ever that this type of document has been created, and it was really a consensus document through all of the organizations that you saw. We also opened it up to public comment. We really wanted to make sure that this was a document informed by the community, which I feel pretty comfortable saying that it was. And here's what's in the standards. I won't go over each one individually, but I think folks on this call would be really interested in number 13, the psychosocial assessment and intervention. But the standards really cover everything from, ethics and qualifications, the difference between a nurse, a social worker, or a patient navigator, all the way through evaluation, research, advocacy, and every point along the continuum of care. So I encourage you to take a look at the standards if you haven't already. If you have feedback, we would love to hear it. Like I said, we want this to be a community-informed document. So before I move into payment, the reason that I wanted to talk about the standards for a minute was because, again, they set the groundwork. Before the standards existed, there was no ability to really reimburse navigation because nobody really knew what navigation was. We knew, those of us who have been involved with navigation knew in our gut and our heart, but it hadn't been outlined anywhere. So with Biden back into the White House, and this is totally nonpartisan, right? This has nothing to do with political party. Biden relaunched the Cancer Moonshot, which is amazing. And when he was back in the White House, his team really worked with CMS to say, okay, we've got this document. Now let's focus on how to get navigation reimbursed. So we're going to talk about a few different ways that navigation can be reimbursed. I'm going to focus on commercial payers and clinical reimbursement for nurses and social workers. And then I'm going to pass it off to Sally, and she's going to talk about CMS and the reimbursement of patient navigation services. And if you're familiar with this information, you're likely most familiar with the CMS information, but we want to make sure that you have the entire picture. So as the navigation reimbursement codes came out, everybody was excited about CMS, excited about the American Medical Association, but they said, what about commercial payers? And so you can see here, we've put a press release from the White House where they brought together commercial payers and different associations, brought them in and said, hey guys, you really need to take this on. So you can see a list of the commercial payers that have agreed to either promote, educate, or cover navigation services and provide reimbursement. So for many of our patients, they will be under commercial plans, and so it's important to know which plans are covering it. This list is not as up to date as it maybe could be. There could have been others that have come on board since then, which we're happy to track down and find out. But the good news is that many commercial payers have signed on, and many of our sister organizations like Community Oncology Alliance or the Association Cancer Care Centers or the Association of American Cancer Institutes has come together to say, we will support this. We will make sure that our providers are trained, that they understand what's going on with the codes, and that they're able to promote and ensure that they're ready to utilize these codes. So really exciting. Wanted to start with the commercial payers. The next piece of this, I mentioned that it falls into sort of two buckets. The first is the American Medical Association and the CPT codes. I am sure everybody on this call is familiar with CPT codes. Again, I am by no means a billing expert, but we know that in order to get reimbursed for a specific service, it needs to have one of several different codes, one of which can be a CPT code. And I know that Sally could talk about this in her sleep because she ran a hospital, and so she knows them very well. But the American Medical Association came out and said, and again, you can see the standards are referenced here on this slide and by the American Medical Association, outlining that there are clinical navigation services and patient navigation services. And so you'll see we're focusing really on the clinical services under the AMA codes. Sally's going to focus on the patient navigation services. So that first piece is really what's under AMA. They're really these clinical services provided by licensed clinical staff, such as registered nurses or licensed clinical social workers. So it's really that clinical level of navigation. And if you look in the standards, you'll see that we've defined the different types of navigation. Here's what clinical nurses do. Here's what clinical social work navigators do. Here's what patient navigators do. So you can see what those services would look like. So the reportable codes, again, they are used for qualified health professionals and clinical staff. These, and again, this is the legalese that's provided by the AMA. One really important thing to understand, both when I'm talking about the AMA and when Sally is talking about CMS, is that the nurse or the social worker can't bill independently, right? They have to be doing so under the auspices of a physician or other qualified healthcare professional. So someone who's qualified by education, training, licensure, and facility privileging when applicable, who performs the professional service, and then they are able to attest that the clinical navigator are providing the services underneath their license. So this comes into play, especially when we're thinking about some community-based organizations who may want to code. It becomes a little trickier, but I want to make sure that we talk about that as we go through this presentation, because CMS has indicated that they understand, if you are a navigator in a community-based organization, you're not working at within a hospital, it can be a little bit trickier to work under the license of a doctor, for example, a qualified health professional. So various different contracts need to exist. I know Sally and her staff have been working on how to improve this, what this looks like. So I'm sure she's going to touch on that. But one of the most important things to walk away from this discussion with is it is not the navigator that's able to bill. It is the navigator under the auspices of the physician or other qualified health professional. So really important to remember. Under the AMA, these CPT codes are known as Principal Care Management, so PCM. You're going to hear Sally refer to the CMS codes a little bit differently. They're known as PIN codes or Principal Illness Navigation, but they're very much related. And so you can see the codes here, which were established in 2022, and they've basically expanded them. They focus on the medical or psychological needs manifested by a single complex chronic condition expected to last at least 3 months and includes establishing, implementing, revising, or monitoring a care plan specific to that single disease. So you'll see here too, it's not just limited to oncology patients. This is true for AMA as well as CMS. It's really about a disease that requires chronic care. And Sally's going to go deeper into what that looks like because it really applies to both AMA and CMS. So again, has to be under the auspices of a prescribing a provider who has the qualifications to do so. And the AMA codes or the CPT codes are specific to those more clinical roles. So clinical nurse navigators, clinical social work navigators. So I think that is my last slide before I hand it over to Sally, and she's going to talk about CMS and the PIN codes. But again, everything is very much related, and I'm excited for the end of the presentation so we can take some questions.
Thanks, Elizabeth. So I am going to jump into CMS and CMMI just a tad. But as a reminder, oftentimes as CMS goes, so does private payers and commercial payers and Medicaid. And so while CMS came out with the PIN codes, which we'll talk about, and CHI, and we were thrilled about that, we are looking for broader adoption. And that's why Elizabeth touched on all the private pay and AMA piece of navigation reimbursement. So just to level set on Medicare, it's our federal health insurance program. Medicaid is at the state level. Medicare is for those that are 65 and older, sometimes younger if they have chronic disabilities, and those with end-stage renal disease. The other thing that's important to remember about Medicare and some of the complicated components is that Part A, Medicare, is hospital and inpatient insurance. It also includes things like hospice and skilled nursing. Part B for Medicare is outpatient medical care and often also includes things like durable medical equipment and labs. I'll come back to Part C, and Part D is prescription drug coverage. Part C is what we call Medicare Advantage, and Medicare Advantage are outside third parties that contract with Medicare to offer plans with A, B, and D in them. Those third parties also often other inclusive things like vision, hearing, dental. So Medicare Advantage is intended to provide some cost savings or lower copays and deductibles, but for all intents and purposes, the three parts of Medicare are A, B, and D, and Advantage may offer some additional things. There is often also, for those that are on Medicare and Medicaid, supplemental coverage. So maybe an employer, a prior employer, a union, a Medicaid program that supplements Medicare. So there's lots of moving parts and components for our seniors to understand about their Medicare coverage. However, when we enact policy, it is oftentimes through CMS, again, with the hopes that our private and commercial payers will follow suit. Next slide. So it's important to understand that Medicare has what's called a physician fee schedule. Elizabeth already talked about CPT codes. The physician fee schedule is a whole host of opportunities for inpatient, outpatient care to bill for services. And all of this is created through rulemaking. That's our policy making process. So when Elizabeth was talking about the moonshot and the opportunity to introduce navigation billing, all of this was through the rulemaking process. Next slide. So the Medicare physician fee schedule reimburses physicians and other enrolled healthcare providers, which we'll talk a little bit more about under Medicare Part B based on the schedule. There are over 10,000 unique covered services. So even though, as Elizabeth said, I ran health administration in hospitals, no one could ever possibly know all of the CPTs and all of the covered service codes under Medicare. But what we do like to draw attention to is different groups and buckets. So when we talk about principal illness navigation and community health integration, there are some buckets within the physician fee schedule that have these things. And the way this becomes a final rule is the rule is proposed. There's an open comment period. Organizations like the Cancer Support Community, the American Cancer Society, CAN, and NNRT, and several other organizations made comments on the physician fee schedule before the final rule came out for 24. And we've, of course, done the same thing pre-25. So for calendar year 2024, the physician fee schedule rule introduced these new payment policies relevant to patient navigation. And what's most exciting to me about that is that it's really recognizing navigation as a profession, as something that's really urgently needed for patients and caregivers in their care journey and their care processes. And so we could nitpick the codes all day long in the introduction and what they covered and how they covered. But I think really the initial focus of many advocacy groups was just celebrating that navigation was recognized as a critical component to care Medicare and that there was reimbursement for it. So the first proposed rule was released in early 2023. The final rule came out in November of 2023, and it was instituted January 1st of 2024. And so then we could start using these new billing codes. Next slide. So same thing in 2025, they released the proposed rule in July. We had until September 9th to make comments on that. And then the final rule will come out in November. So we don't know yet what the final rule will say for 2025, but we do know that that implementation will take place on January 1st. CMS is requesting information on additional policy refinements, things like auxiliary personnel and certification or training requirements that aren't, really well explained or adequately captured in the current rule. And so I would say CMS has been really open to hearing feedback, receiving feedback, to the comment letters. They know as much as we do that this is an evolution and that it's going to take time. And there has been some hesitancy in the first year in implementing codes due to several barriers, one being that there's a coinsurance and copay. I'll talk a little bit about how the codes are billed. But again, Medicare has been really open to hearing that feedback from us, and it has helped having the moonshot help us create those conversations. Next slide. So here are the codes as they exist today for principal illness navigation, community health integration, and social determinants of health. So I'm actually going to start at the bottom and work my way up. So the social determinant of health risk assessment typically will take 5 to 15 minutes, or that's what it's reimbursed for, and it can only occur every 6 months. And the SDOH risk assessment does have to be completed by the primary care provider, which in this case could be the medical oncologist or a primary care physician or their staff within their office. Community health integration is something that can be billed at an hour a month for the initial visit and then additional 30 minutes within the month. There's also a special code for FQHCs and RHCs. I am not going to tell this group what the health-related social needs are because I think for the most part you know what those are and have been working in and around them for years. They are a little bit different than social determinants of health, and I'm going to go over in a moment on a later slide kind of the 9 categories of community health integration that are included in these codes that you see on the screen. And then at the top of your screen here, principal illness navigation. Basically somebody with a chronic illness or a high-risk illness that requires a care plan that is going to be seen over a lengthy period of time. There's actually some special carve-outs in here specific to cancer, and you can see that there are several codes here, including PIN services, initial visits, and follow-up visits, as well as peer support. And again, as Elizabeth talked about some of the navigation standards, when you think about peer support, and as this reads today, a lot of that are patient navigators and those out in the community supporting patients and caregivers. Next slide. So what I really want to touch on here is that, again, PIN codes are only for Medicare patients. Even though Elizabeth went over, kind of the AMA statement and some of the coverage by other payers, today this is only a Medicare patient. It is someone who has a serious high-risk condition, which in most cases is cancer and other long-term chronic diseases. Their care is expected to last at least 3 months, which I can't think of any cancers where the care would be less than 3 months. So again, meeting criteria there. There is significant risk of hospitalization or skilled nursing care or acute exacerbation of their disease, functional decline, or death, and they do require a disease-specific care plan. So we'll talk a little bit about documentation of navigation services and how we're going to bill for those services, but remember that it all kind of links back to that original care plan. Next slide. So I also want to point out in this side, when we talk about who can provide PIN services, we also need to think about over what period of time we're providing PIN services. And I will tell you that as of the existing codes that exist today in the physician fee schedule for 2024, it's basically at the time of diagnosis. And so there has been a request for clarification from Medicare of what about the process of screening and into survivorship. And so we're awaiting clarification on that. As Elizabeth said earlier, basically a clinical nurse navigator, a social work navigator, a patient navigator, or a certified peer specialist can be providing PIN services, and they're under the direction of a physician or other practitioner. And below what I've put here is that is considered incident 2. And basically what incident 2 means is that we hold a contract with that physician or practitioner that's overseeing that patient's care to provide certain components of navigation or community health integration. Those contracts could be, pieces and parts of that navigation. It could be a comprehensive agreement with that provider. So I can't lend you too much information on what those agreements should look like, but it's really a contract between you and that provider who is contracted with Medicare to bill for services. And that is the incident 2 piece. One of the concerns within incident 2, and I'm being very frank as a community-based organization, is that since I am not directly billing Medicare for those services, when I contract with a healthcare provider, they may say out of every dollar that we're reimbursed, we're going to give you 2 cents and we're going to keep 98 cents. So we have put into some of our comment letters considerations for community-based organizations. And CBOs also have some concerns about that copay and coinsurance because financial toxicity is one of the main things we could be navigating. And so we better want to understand if there are any options to remove some of the financial barriers to billing these PIN services. Next slide. So these are the 9 categories of services under community health integration. And I will tell you at some of the state level community health worker programs, I've seen a lot of these built into those as well, and so can sometimes be synonymous. I also love that every single one of these categories, I think really hit it home when it comes to health-related social needs, very comprehensive. And again, we should all be celebrating that Medicare is acknowledging how critical some of these services are. The 8th one on the screen there, providing social and emotional support, is near and dear to my heart and to cancer support community. But really all of these are really important for kind of whole person, whole patient care. Next slide. So training and competencies. There's been a lot of conversation around this, before the physician fee schedule came out, through the building of the standards, and now that the physician fee schedule was released for 2024. So there's some great programs out there like the ACS Lion program. GW has a great program, the Smith Center that Elizabeth mentioned earlier. There are several state level programs for community health workers, but training and competencies for navigation basically need to include these components and are recognized then as that person having gone through the core competencies in order to bill for these PIN and CHI codes. So I think, as we mentioned before, that there has to be an initiating visit before PIN codes can be implemented. Oftentimes at that first visit, it's again the primary care provider. A social determinant of health screener is done. Remember, you can get reimbursed for that, and it takes about 5 to 15 minutes to do that screener, and you can do it every 6 months. And then you can initiate the PIN services and CHI. That is under the auspices of a care plan, which means that if you're a healthcare provider, the care plan has to reflect that navigation services are being initiated. Or if you're contracting with a healthcare provider, and remember, as incident 2, again, you need to understand what that care plan says so that you can follow suit. And I'm going to go to the next slide to talk briefly about consent. There does need to be a written or verbal consent for the patient before PIN services are implemented and put into place. It has to explain the cost sharing. And so that's what I was mentioning before about some of the community-based organizations, advocacy organizations, and others are worried about copay and coinsurance that comes along with Medicare billing, because when these critical navigation services are put into place, oftentimes it can be because there are financial toxicities. So I'm just putting that out there into the world because there's much more conversation to be had around it. That consent does have to be obtained annually, so many of these patients are seen and followed over the course of a few years, sometimes much, much longer, and annually you do have to get consent to initiate those PIN codes, and it can be obtained by auxiliary personnel within the provider's office. And then last but not least, when utilizing the PIN codes, you do have to document in the medical record. This becomes pretty critical because, as you can imagine, an oncology patient could be seeing a medical oncologist, a surgical oncologist, a radiation oncologist. They may have someone in the community that's navigating their social emotional support. And so that documentation that aligns with the codes and those 9 categories of community health integration are important. So if you're the provider, it's finding the space to create that documentation within your EHR or EMR. And then if you're an incident 2 or contracted service, how are you going to bring that full circle and provide the documentation in the medical record? And with that, I am going to turn it over to Elizabeth to talk about FAQs, and then we'll have plenty of time for questions.
Awesome. Thanks, Sally. So hopefully everybody now has a general understanding of reimbursement of navigation services overall, but we recognize that there are a million questions that could be asked. And so I wanted to draw everybody's attention to a really valuable resource. Sally and I both sit on the National Navigation Roundtable, which is an entity brought together by the American Cancer Society, where many of the organizations who do a lot of work around navigation come together to support sustainability, to support reimbursement, to really focus on how to keep the profession moving forward. And so on that website, you can go and find a living FAQ document. So this document, the Policy and Advocacy task group that works within the Navigation Roundtable put this document together because we were constantly getting questions around, well, what does that training look like? And where do I need to be employed? And how do I implement these codes? And so I just listed here the different headings in the FAQ. So things like employment setting. Can I work in a hospital? Can I work in an outpatient clinic? Can I work in a community-based organization? Training and certification. Sally went over the various different competencies that are underneath the training. And we were getting questions like, how does a navigator prove that they've gone through the training or that the training was appropriate, right? And the answer is the training just has to adhere to those various different competencies. And as Sally said, there are many different trainings that can apply to that. Some of them cost money, some of them are free. And so it's really up to the navigator in the program which one that they take. And then the provider that's overseeing the navigator is attesting that the navigator has been trained. Different billing and payment questions, service delivery, other topics. if I wasn't sharing my screen to show the slides, I would show you this FAQ document. But excuse me, if you go to this website, to navigationroundtable.org, and I just did it on my phone, if you type in the search bar FAQ, it pops right up. And like I said, check back often, because this document, as we're getting more questions in, as folks are implementing the codes, and we're learning more about what what questions there are, what barriers exist, we are updating this document. We will also, and Kelly Hendershot is the best. She's already put it in the chat, which I'm not surprised by at all. So you'll be able to access that. But again, living document, it's all the information we have right now. And then, as you can imagine, when CMS updates the physician fee schedule by this November, as Sally said, and if AMA updates their CPT codes, and if there's any updates on commercial insurance, this is the document that we will go back to and update. I also encourage you to visit navigationroundtable.org often, because there's always new resources coming out. I hope that many of you are engaged through your organization in the Roundtable. And if you're not and you want to be, happy to have conversations with you about that. But the American Cancer Society has been a great partner. Cancer support community has been a wonderful vocal advocate for this. And it's really a good, I'm not going to say one-stop shop, because there's lots of great navigation resources all over, but they do a really nice job of pulling in those resources from other websites, other organizations like the Cancer Support Community. So this is a really important resource for you to have. And then I also wanted to just share a few other things. I believe that everyone will get a copy of these slides, and so you'll be able to click on the links. But Navigation Roundtable, the AMA CPT Assistant, which outlines all of the information from the AMA. We also put the 2025 physician fee schedule, so you can go in and see when it's being updated. And then we also included a variety of the White House Moonshot resources that, if you're just interested in learning more about the background of this work, you can check out. They had a Q&A session on navigation codes, which helped to inform the FAQ document that we put together. They have a variety of frequently asked questions about the physician fee schedule, and then also that press release that you saw in the beginning in terms of payers and providers stepping up to advance navigation. So again, the Moonshot, the White House Cancer Moonshot, has been an invaluable leader in this process, making sure that that navigation is really at the forefront of cancer treatment. I see a question in the chat that I think we can go ahead and kick it off in terms of our questions, but Sally mentioned this, and one of the things that the codes were specific to this time around, right? So we're talking about the 2024 codes. We don't yet know what it's going to look like in 2025, but is really around that time frame that patients have to be seen in order to receive navigation services. So it's really about current diagnosis. And so, Sally, I don't know if you want to comment. I know Ruth put in there palliative care and then the full continuum of services.
Right. So within the Q&A, I see the cost sharing amounts and the copay and coinsurance and what is the billable fee. So remember, Medicare has these really fancy equations that look at state-based reimbursement. So unfortunately, there isn't standard Medicare reimbursement. It varies from state to state. But I will tell you the PIN codes are reimbursed. Well, social determinants of health, community health integration, and PIN codes are reimbursed anywhere from $25 up to about $150. It varies greatly, again, based on what state. The copay and coinsurance, also a little bit complicated, because a lot of patients have a Medicare Advantage plan, which means that their copays could be different based on what Medicare Advantage plan they have subscribed to. But when you think about your own health insurance, oftentimes you're paying like a $10 copay to see a primary care physician, maybe a little bit more to see a specialist, and then dependent on inpatient, outpatient services. But what I can tell you is that if there's a copay or a deductible built into that Medicare Advantage plan, navigation is not, of course, exempt from that. And so there is going to be some dollars passed on to patients. And then there's also a Q&A in here about independently billing Medicare as an LCSW for the PIN codes, which unfortunately, the way I understand it, I don't think you can independently bill Medicare for the PIN codes, but you can for the community health integration codes. But again, this has to be documented in the medical record with the primary care provider. So you'd still need some type of a business agreement and information sharing, because the goal of navigation again is coordinated care as well. Elizabeth, anything else on that?
No, I absolutely believe that you're correct about that clinical social work question. It all has to be incident to provider. Kind of coming back to Ruth's question in the chat, what about palliative care? One of the things that I know, and another good resource that we can make sure folks have, the American Cancer Society Cancer Action Network did their comment letter to CMS for the FY 2025 codes. And one of the things that they noted was right now, it's one physician overseeing the care of the patient, and they're the ones, they're following that patient, and they're the ones that the providers are incident to. Well, we know that there are often many different providers that patients are seeing, right? Whether that is your palliative care provider, your oncologist, it can be a variety of different providers. And so what about making sure that you can bill for all of the various different services? And also even, right now, what if you have a nurse navigator who's doing clinical services, or a social worker, and then you also have a patient navigator? Can you bill at the same time? So these are some of the questions that are being worked out, and some of the comments that have been made to CMS. One of the things that Sally noted earlier in the presentation is that the uptake has not been huge. And I think that's important to talk about, because I don't think it's for lack of interest, right? And we wanted to make sure that in comments back to CMS, we said to them, like, don't take the lack of use of the codes as indicative that people don't want to use them. This is so new, right, to navigators who've never had to worry about this before. It's so new to programs who don't know how to implement it, that they're trying to learn from one another. So one of the things that we are doing with the National Navigation Roundtable is looking at some of those settings that have really utilized the codes very favorably, ones that have gotten over some of the barriers that are present, and getting those lessons learned and trying to find out how they did it. I see one of the questions in the chat is examples or samples of contracts that a community navigation program would use. This is something, and Sally, I'll let you answer it because I know it's based on community organizations, but it's something that makes me think this is absolutely, without sort of overstepping the bounds of legality in terms of saying this is a contract you should use, but like, what should you be thinking about when you're thinking about a contract? And we're trying to pull that type of information in terms of lessons learned and best practices from the Navigation Roundtable. But Sally, would you add anything there about draft contract?
Yeah, what I would say is that those contracts, to be incident to, you're going to want to be pretty explicit about the services you're providing, and you may actually spell that out by the PIN code and CHI, so that it's clear what you're providing and what they're expecting and what they're able to bill for. But also what I recommend within that contract is a business associate agreement, because you're going to be sharing sensitive information under HIPAA. They're required as the primary care to hold that care plan. And again, you want to react to and support that care plan. And then I see a question in here about nonprofits providing supportive care and anything they should know about the PINs. Nonprofits should know that you can be part of this PIN code reimbursement, but it's through a contract right now with a provider. Otherwise, you're doing much like CSC is doing on our helpline, which is providing free services that we have for 42 years, and not making many changes there under CMS or billable services. The next question is talking more about financial toxicity, and billing can impact patients directly. So I think, that the billing piece and the impact on patients with financial toxicities is kind of the elephant in the room, that a Medicare patient, and even if it's, let's say, a Blue Cross Blue Shield that's agreed under plans that you can bill for navigation services, there is that risk of copay and coinsurance. We have made some comments to Medicare and even some recommendations around that, but as the codes exist today, copay, there is that risk of financial toxicity.
And Sally, can I just add to that? It is not due
Yeah.
to Medicare wanting people not to utilize the codes. It's legal, right? When Medicare was established, there was a legal precedent set that there had to be a copay associated with Medicare services. So the things that are being discussed right now, the Patient Advocate Foundation has launched a copay assistance fund. It is a Band-Aid for sure, but it's wonderful that they've done this. And so if patients are able to seek assistance through those types of funds, that's fantastic. But I do know that many different people have commented to CMS for FY 2025 about the copays. And the answer is going to have to be creative, because it would either have to change the statute, which frankly is not going to happen, because to open up Medicare is very difficult and comes with lots of unintended consequences, and it's just not something that I see happening. But there could be other creative ways to think about this. So stay tuned, but it's something, as you're working with patients, that's really important to understand, because even though it is a relatively, to those of us on the call, it may be a relatively small amount of money. To someone who's struggling and really trying to make ends meet, it could be a significant factor between if someone's seeking navigation services. It's also a best practice that we're seeking through the Navigation Roundtable to understand how navigators are helping patients to understand and make sure they can still get navigation services even with that copay. And I saw this question here, which is a really good one, the difference between the PIN codes and the HBAI codes. The HBAI, the Health Behavior Assessment and Interventions, these are really much more focused on the mental health side of things, right? And so it's billed directly by social workers, marriage and family therapists, and mental health counselors, as well as clinical psychologists. So these are going to be much more tight. Like when you think of a clinical social worker, much more of those standard clinical social work type of services, whereas the PIN codes are much more focused on your standard navigation. So I can't give you kind of a parallel comparison of the two off the top of my head. But when someone asked earlier, can social workers bill directly for PIN codes? No, because these are navigation. But for HBAI codes, yes. And so I think, frankly, they would work really well together. For those patients who need more specified and more specific clinical mental health assistance, those HBII codes would be important.
Mm-hmm. Agreed. Those are great questions.
They are great questions. Every time we talk about this, we get a ton of great questions. And I know as people absorb and think about this, other questions will come up. So like I said, Sally, I'm always available to help. And I know you've been wonderful with this too. So I believe we'll get the slides out to folks so they'll have access to all of the resources. And as they absorb them, I'm going to put my email in the chat. And if I can ever be a resource, people are more than welcome to contact me. And I know Sally, the CSC team, is fantastic with all of this information as well.
That's right. And this session is recorded. So if there's others within your team that you want to take a look at the session with you, and also Elizabeth put up a bunch of links to resources. So you'll get these slides with those active links to those resources as well. And then, in November, we'll learn what the physician fee schedule is for 2025. And then we'll have a whole new conversation about where PIN codes and CHI are going into the next year.
Yeah, I was going to say, Sally, I am confident that through the Navigation Roundtable, we'll be hosting updated webinars about this. And so would love to invite all of our CSC family members to come and join those, because the more information we get out about this, the merrier.
Yeah. And the only other thing I'll add is that some of those comment letters out there, the American Cancer Society, an NNRT letter, as well as CSC prepared a comment letter along with Cancer Care and the Patient Advocate Foundation. If anyone actually wants to see our comments on the proposed physician fee schedule, we're happy to share those comment letters so you know where our primary congratulations, celebration, and concerns lay with CMS.
And at the end of the day, it is all good news, right? There are improvements to be made. we always can handle billing amount. Reimbursement rates are a little bit higher, but at the end of the day, as Sally said, this is really, really good news for the field of navigation. For the first time ever, the federal government is recognizing how important navigation is. And I think that's a testament to organizations like the Cancer Support Community, like the National Navigation Roundtable, and everyone on the call who've been doing this incredible work, because you're showing that it's working and that it's worth investing in. Because to get a reimbursement code from the federal government is no small lift, right? It costs money, and that is always a hot topic within the federal government. So just a huge kudo to everybody on this call, folks who are on the ground doing the work, because the work you're doing is working, and it is filtered up to the highest level of the land, and they are willing to invest in it. So it's really an awesome time to celebrate, and I think it's just going to keep growing from here.
All right.
Thank you, everyone who attended today, and I'll let Marcy close us out.
With no further questions, that marks the end of this session. Thank you so much, Elizabeth and Sally, for being with us today, and thank you to our audience for joining. As a reminder, as Sally mentioned, this session was recorded, and the link to that will be available for viewing on our CSC Zoom Events Hub and on CSC's Learning and Training Program website, and we'll be able to see until February 10th of 2025. PDF versions of the presentation will also be shared with attendees following the event. And please note that all session recordings and resources available after the event are for informational purposes only and will not be eligible for CEs. If you wish to receive 1 continuing education credit from participating in this session, you must complete an online evaluation form. The link to this form will be made available after every session, but please note that you will only need to fill it out once to claim the credits. If you have questions about the C activity, please contact Prime in the email shared in the chat. Thank you again for joining us. We'll now take about a 15-minute break and return at 3:45 p.m. Eastern. We hope to see you in our last session of the day that will discuss the impact of cancer-related cognitive impairment on patients and caregivers. Thank you all for joining.